I'm your host, Dr. Manjunath. I'm a pediatrician and an asthma specialist based in Bangalore. I also have special interest in infectious diseases and vaccinology. Today, we have two eminent personalities. One, Dr. Neminathan from Coimbatore. He runs a 100-bedded hospital called Coimbatore Medical Center in Coimbatore, and it's a fantastic hospital. Once anybody who is in Coimbatore, just go visit his hospital. He's going to help you out a lot. And then it's my pleasure to introduce my good friend, Dr. Prasanna Raju. And he is a very pleasant personality, very knowledgeable, and he has a lot of accolades under his belt. So, with this introduction to the topic of influenza for 2025, uh, we will start with the discussion, the informal debate. We will not be having any presentations. It's just a formal discussion of what we should be expecting out of influenza for 2025. So I request Dr. Prasanna to answer some of my queries, what I have today for influenza.
Sure, sir. Thank you. Thank you for having us in the show.
Sir, what is the change you have seen in the previous years to this year in influenza?
So, compared to the previous years, this year the onset of influenza itself is little late, and the peak has gone down to August for especially in South India. And we are seeing a lot of children with H3N2 variant. So this variant is more prevalent now, and there are more hospitalizations with this variant. And the pattern which we are seeing is there is no problem. The children has high grade fever, then they have symptoms of dehydration, so all these things, and then the dry cough starts after 2 3 days later. So and the even the infection is little prolonged this season. It takes 5 to 7 days for them to get better. But we have not seen any more severe cases this season. It's all cases who have taken 5 to 7 days, but they get better with good hydration and paracetamol. So more H3N2 and more cases who has a prolonged infections.
Sir, Dr. Neminathan,
Yeah,
uh, I mean, how would you differentiate influenza from other viral illness and
yeah,
influenza to other bacterial illness? So this is a common thing what we see. Many of us pediatricians, what we have been practicing, we believe that we are capable enough to identify clinically. Are we really that good in picking up viral from influenza and influenza to any other bacterial illness? Is there any specific patterns for us or a clinical clues for us to identify what sort of a disease it is?
yeah. Thank you, Manju. Friends, in fact, influenza as such, we call it as ILI, influenza-like illnesses. There are around 6 viruses that belong to this family: influenza, parainfluenza, human metapneumo, adeno, rhino, RSV, and even human coronavirus. Many viruses have got the same uh, type of illnesses. So it's very difficult to differentiate among this family, but only certain clues will give us a clue because, as per the New England Journal of Medicine, influenza in younger children has got a periodic pattern, that is, sudden onset of abrupt onset of high grade fever with a sore throat, followed by a dry hacking cough with severe myalgia, body pain, lassitude, tiredness, loss of appetite. Sometimes influenza A has got predilection not only for respiratory, it has got predilection for the GA also. They might have abdominal pain, that's called gastric flu, vomiting, diarrhea. That will give us a clue. Influenza B has got predilection for muscles, myositis. So you can have a clue by looking at this child. So if there is a family member having a similar illness within a couple of days, same time, it means swings the pendulum towards viral illnesses, and a sudden onset of abrupt onset of high grade fever in a healthy child swings the pendulum towards viruses, whereas in bacteria, the incubation period is little prolonged. One of the family members has a typhoid a week earlier, or somebody has a pneumonia a couple of days earlier. The incubation period is long. If the incubation period is ultra short, sudden onset of high grade fever in a well happy child, rough breath onset with a more than one member in the family having fever at the same time, swinging the pendulum towards ultra short incubation period, and more sites that are involved. Eye is involved, eye is red, nose is watery, throat is congested, with multiple system that is involved. Cough on auscultation, get a wrong eye. On GA, you have a watery diarrhea, abdominal pain, vomiting. Skin, you have a rash. Multiple system involved. All these things with the in influenza, we always call a rule of two. Few hours, 2 hours to 2 days of incubation period, 2 days of fever, 2 weeks of cough, and in severe influenza, 2 months of asthenia. All these things, this is called rule of two. If these things follow, you probably having an organism, probably influenza, that too during an influenza season. uh, when you're near the equator, you don't have a season. You have influenza throughout the year. When you go away from the equator and the tropical zones, you have influenza. Seasonality is there. So you may not have a particular season, but when you have a follow this set pattern of symptoms, uh, then you can come to a reasonable diagnosis. It's a short pyrex illness, probably viral, probably influenza. You have to keep an eye whether the child has got comorbid conditions, because the categorization depends on the comorbidity. So your need for starting oseltamivir also depends upon the WHO categorization. So definitely, many of the viruses that belong to ILI family have got the same symptoms. You cannot strongly say it is influenza, but you can say it belongs to ILI family. But definitely we can rule out bacterial by looking at this. Only one virus that belongs to viral family has a bacterial great mimicker is adenovirus.
Adenovirus,
It has,
yes.
yeah. If you even if you do a lab test, counts are high, CRP is high. The child has got a urine pus cells. The child has got a pyuria. All these things, it's a great mimicker. But for adenovirus, other viruses, definitely we can definitely say it is viral.
Yes, sir.
Dr. Prasanna, what is this big deal about the influenza pyramid? Do all of those influenza affected patients go through the same symptoms, or only few need any help?
Uh, since you have asked this question, I'll just put it like this. There are certain categories of infection. Some children, they just pass on with fever, cough, or sore throat, or just some coryza, or as Neminathan said, body pain, muscle pain, myalgia, and headache. So these are all category A symptoms. They can have vomiting, which is acceptable. So in certain children, they can have irritability, then poor feeding, and they can even have fast breathing. So these are all children who will have some category B symptoms. And some of the children can have complications of influenza like a pneumonia, altered sensorium. Then they can even have seizures, hypoxia. So these are all category C symptoms. So some children can even end up with encephalitis, myocarditis, or even some children can have exacerbation of their asthma status. So these are all children who requires admission and who requires monitoring. So category A symptoms, we can treat it as OP basis, give them adequate fluids and paracetamol, advice on the warning signs. Category B symptoms, we can have a watch, give them fluids if necessary. And category C symptoms, we need to admit them and we have to give them antiviral, oseltamivir, and then we have to monitor them in the ICU. They may need HFNC, or they may need oxygen support, or they may need even ventilatory support, and they may need management of shock if it is there, and multi-organ dysfunction if some children goes on to multi-organ dysfunction. So that's how there are three categories. As you said, it's like a pyramid. Only very few will need intensive care monitoring, and especially if they are susceptible, like young children, less than 6 months, or adults who are pregnant, and then who has a premorbid diseases with kidney failure or heart disease, pre-existing heart disease. So these are who needs more care.
Yeah, well said, Prasanna. Audio is not there.
Any
Yeah,
So this
points to
was
be
a
Prasanna.
added, sir?
fantastic explanation, sir. So
Prasanna, Manju, shall I add some flavor to this?
yes, sir. I was about to come to you, sir.
Yeah,
Uh,
yeah,
since you own a hospital, you
yeah,
are the right person to
yeah,
summarize this.
yeah. It's well said. Prasanna, it was a good point that you brought everything in a nutshell. Because many a times we see children coming to us with a viral illness and we make a diagnosis of influenza, particularly during monsoon. So, as per WHO, what we need to do is we need to categorize them so that we need to plan what is the strategy we are going to adopt. As if you look at the pyramid, 90% of them are category A, then 9% is category B, and only 1% is category C. Category A is vast majority of them. If you see, for example, in OP 100 children of flu, 90% do not need any treatment. Nature cures them. You don't give any medicines. Just talk to them, reassure them, tell them about warning signs, and then no need for tests, no need for antibiotics, no need for antiviral. Just home isolation is important because they keep spreading. The RO is very high in flu. If one child goes to school, it will spread the influenza to the whole classroom. So RO is very high in influenza. You should not. You need to tell them to home isolation for a period of 5 to 7 days. Just home isolation. Most important thing is no antibiotics, no steroids, no NSAIDs because of the fear of race syndrome. Nothing. Only thing is you can tell them to come back after 2 weeks and come back for a flu vaccination. So 90% do not need any treatment. Nature cures them, number one. 9% of the children who have a severe disease, they are not tolerating food, or they are looking sick, they are toxic, they come to category B. Sometimes if they have got comorbid conditions, like 10 comorbid conditions are there: chronic disease of the heart, chronic disease of the kidney, chronic disease of the liver, chronic disease of the brain, chronic disease of the hematological system, or any immunosuppressed state acquired or congenital, or the child is less than 2 years of age, child has got obesity more than 40 BMI, or the adults more than 65 years and pregnancy. These 10 conditions, automatically even a minor flu becomes category B. Even a minor flu becomes category B. In category B, what you need to do is, having made a category B diagnosis, based on your clinical judgment, you can give oseltamivir without doing RT-PCR. That's the most important thing. Here, you have the power to give oseltamivir without doing any test. That's called category B. And please remember, do not misuse oseltamivir. If you misuse oseltamivir, like antibiotic, we'll also get flu which is resistant to oseltamivir. You have to use it only in 9% of the cases with your clinical judgment. Here also, there is no role for antibiotics. Please remember, there is no role for secondary bacterial illness, even in children with category B. And the 1% is those who got danger signs: tachypnea, dyspnea, cyanosis, hypoxemia less than 95, hypotension, shock, delusion, disorientation or dizziness, seizures, dehydration. These children, there are danger signs, they automatically become category C. In category C, if you are practicing in a small nursing home or if you have a small clinic, first thing is you have to refer the child if they have got danger signs. Number one, in a hospital like us where we have ICU, PICU, we do six things at the same time. We admit the child, we isolate the child. On one hand, we give oseltamivir, another hand, we take RT-PCR, we intimate to the health authorities. All these things has to be done at the same time. So this is very, very precious. And 25% of these children with the category C do go in for pulmonary sepsis, pneumonia, ARDS. They require third generation antibiotics, particularly in category C. So this is only 1%. For every one child you see with category C, there are around nearly 99 children in the society who are category A and B. So that's a reflector of what we see is only tip of the iceberg in our hospital. So
Yes.
one point I want to add, as Sir
Please, sir.
said,
Please, sir.
this Vasantamavir is being abused by a lot of practitioners. So, for even for category A
Now, I was
symptoms
coming
or
to that question. Like,
non-influenza illness.
uh,
yeah.
so this is where we all go wrong. We preemptively consider giving oseltamivir, whether it is needed or not, because you cannot be penalized for starting. If you are not starting, at least somebody can question you. That is where the problem is.
Actually, this year I read about more about Vasantamavir. This Vasantamavir is actually made from shimic acid. Shimic acid means it is something which one of the spice we are using. You call it a star. Star is a Chinese herbal. So they are bringing that star or anise, they call it as, and they use this in biryani and all. And that's a very strong acid actually. I have seen a lot of children who have been started oseltamivir earlier with for minor symptoms, who has developed severe gastroenteritis, vomiting, and that has worsened, in fact, their flu. More than the flu, it is this vaseltamivir that has worsened their state. So I think, as I said, only the tip of the iceberg needs vaseltamivir. So, and
Yeah.
if they have a pre-existing comorbid disease, all the 10 diseases that Sir said. So, rest assured, I think paracetamol and fluids. More importantly, fluids.
So
Anything
here
you
the
want to add,
takeaway
sir?
says a lot of cases are there in the community. Only few get to the notice of the doctor. Some go for severe and some go for extreme cases. So this is a simple understanding. So just because some person has influenza infection, not necessary they have to be treated, not necessary they have to be admitted, not necessary they have to be started with oseltamivir. These are the takeaways what we are going to take at this point. So this is a question to both of you. Are there any genetic markers for us to say this person is likely to go for severe disease, this person is not likely to go for severe disease? Are there any such markers for us to predict? Because as we know, only few of them go. Even healthy adults with no comorbids go for ICU with influenza. Like COVID, do we have any such markers for us to work on it? I mean, sir, anybody can answer, sir, in this
Yeah.
case.
Yeah. Of course, definitely when there are I'm not sure about the markers, but only thing is those children who got comorbid disease, definitely you have to be cautious. These children are the morbidity mortality is very high in children with comorbidities, not only for flu, even for COVID or other children's. During COVID time in our hospital, we had lots of children who went in for ventilation, who were obese, BMI more than 40, went in for weeks and months of ventilation in our PAC. Prone ventilation, we had difficulties. Obesity is definitely one of the something any obese child having a flu is very, very important. Young children and other comorbidities, which I told you earlier, definitely is for a clinician, it should give you alarm bell.
Okay. After having gone through the signs and symptoms, after having gone through the treatment part of it, so I want to ask this question to Dr. Prasanna, because you are working in a medical college. Has the influenza vaccination has had any impact in reducing the cases, or is it, or has it altered how does it present to you in your clinics?
So basically, in my clinic or be it in the hospital, Uh, from June or July, we start giving away messages to the patients. So we tell them that the flu season is going to start. We have boards displayed. So the influenza vaccine is new strain, if it has come new strain, or the old strain is continuing. So they have
Like
to
this year?
take this vaccine like this season. So they have to take the vaccine. We start giving out messages. So if we give messages to 5,000 families, at least 200 to 300 families come and take the vaccine. They know they have already suffered. They know what is flu very well. So they will come and take the vaccine. And as far as in the clinical practice that I have seen, those families, some take with the family. Even the adults take. So those families uh, do well in the season. They just pass off, or even if they get an illness, it is a minor illness. So and more so over, I recommend all the healthcare workers, especially the doctors. So they should go and give to their parents, their children. So because they are the carriers. So some diligently take this up, and I think as far as I've seen, these people have not have not suffered much in the season. And one more personal experience I would like to tell. I think this may be some message for some people. Um, this influenza vaccine has a rare side effect of cervical lymphadenopathy. It's not cervical, it can be a lymphadenopathy, generalized lymphadenopathy, because I have given to some two or three children and I have observed them coming back with the lymphadenopathy. Then I went and referred in CDC and I got this information. Then once when my son was very young and I gave him influenza vaccine, he developed intussusception. So we checked his notes and immediately after 2 days of vaccination. So we checked his notes. His notes was positive, and so the notes was the reason for interception. Luckily, he just escaped with the air reduction. So and the next year when I gave him again, and he developed the same interception. It was a recurrent interception. So then I realized I should not give him influenza vaccine. I've decided, so this year I didn't give him influenza vaccine. Rest all took in our family, and he had 1 week of illness, and none of us had. There was personal experience, and I'm telling this experience from all the doctors whom I have given. So that does work well. Actually, the vaccination does work well. What is your experience at Neminathan, sir?
I mean, this is a fantastic insight, sir. I mean, I have not experienced that lymphadenopathy and problems associated with
Yeah.
vaccination per se. I mean, we give a lot of vaccines in Bangalore, and the influenza incidence as such has come down. First thing.
Very much.
And coming to the side effects part, as I said earlier, we have not seen much in this Bangalore city. At least, I mean, I have been in multiple groups where this side effect has not been inspected per se.
Even this is reported in very few patients, very few patients. So it overcomes, it overshoots all the benefits of that the vaccine has to offer to the
Yeah.
humanity.
So that's why I
Yeah.
selected a panel where it represents three parts. One, the typical urban like Bangalore and Chennai. One, a semi-urban like, I mean, tier two city like Coimbatore. So that gives a perspective for everybody in the country to understand what we are going through. So that's
Yeah.
exactly the reason why we had this varied
In,
panel.
yeah. In fact, I am closer to influenza because I've been one of the members of Influenza Foundation of India. Personally, I'm
Wow.
taking this vaccine for the past 20 years. Myself, I'm taking for the past 20 years. So I could see I'm asthmatic. The number of episodes of asthma has come down after taking this vaccine. So my personal feeling is that definitely all doctors must take, apart from our regular recommendation by pediatricians from 6 months of age to 49 months of age, children with comorbidities, including under 5 asthma, and also adults who are immunocompromised or children who are immunocompromised, and definitely pregnant mothers if they are in the influenza season, it's a safe vaccine to take inactivated vaccine, not a live vaccine. So these things are very, very important as a practitioner, we must follow. Another important thing about this vaccination is that it not only reduces the influenza, it reduces the complications, secondary bacterial pneumonias, hospital admissions, ICU admissions, particularly in the sector of children who have this comorbid disease. Definitely, it not only reduces influenza per se, it reduces the hospitalization also. Number of hospital visits, number of antibiotic requirement. It has come down. Though we don't have a published data in our hospital data, the number of children who have received this vaccine, their hospital visit and antibiotic use and ICU hospital admissions have come down.
Oh, fantastic, sir. I mean, we have a similar experience even in Bangalore. So though we do not have any published data, but definitely the incidence has come down to a large extent in the Bangalore. With the
Yeah,
consequence,
and also
allergies.
I'm sure that I need to add a point about this vaccine. Now we have a trivalent vaccine.
Exactly, sir. I was
Yeah,
about to ask
yeah.
that question
Previously,
to you.
we needed a tetravalent vaccine. After COVID, somehow that Yamagata strain went away. I don't know. It went away along with COVID, I think. So that strain is not there. So now we have a trivalent vaccine: A H1N1 Victoria, A S3N2 Croatia, and influenza B. That's also Victoria lineage. So these are the things in the present vaccine. And regarding your southern hemisphere, northern hemisphere, these vaccines are given to entire population, in children, comorbidities, adults. So the large number of people are taking this influenza vaccine. The factories that manufacture are only couple of factories, only two. So for the whole globe, they cannot manufacture. In southern hemisphere, we get the monsoon the month of March, April, May. So those countries that are in the southern hemisphere, like New Zealand, Australia, South America, they get the vaccine earlier during the pre-monsoon time. So those countries who are in the northern hemisphere, like North America, India, Russia, all those countries, in the northern hemisphere, we get the monsoon, particularly in the later months, in the August, September, October, November, December. So we get the vaccine later. This is for the pharmaceutical company to do this. I'm also part of the WHO Influenza Surveillance Network. I'm a sentinel doctor. I take samples from the nose of the children who have present to us for ILI. We send it to Guindy. From there, it goes to NIV Pune. From there, it goes to CDC Atlanta. From there, the entire global data is given to WHO. They know what strain is prevailing in particular country, world, which is going to come up in the next future. So the WHO recommends the vaccine manufacturer to produce such a vaccine. So this is a continuous network. I'm there for as a sentinel doctor for more than 25 years. So this data is constantly updated. So though we are from a smaller place, we do contribute for this flu for the vaccines.
Oh, fantastic. So this was something news to me. I was not aware of it. I'm just too probably not aware of this part of it. But this is a fantastic information, and kudos to you, sir.
Thank you.
Yes, sir.
So
And more importantly, because of this one strain reduced, the cost of the vaccine has come down.
cost has significantly come down.
Come down. So I think more people will take it, and more people will
Yes, yes, it
benefit
becomes more
because of that.
affordable.
Yeah.
Yeah. So I think we have covered most of the influenza part, starting from the signs, symptoms, and when to hospitalize, when to treat with oseltamivir, and when to vaccinate, and what to vaccinate. So with this, I think this was a very fruitful discussion, and I think a lot of people will get benefited from the eminent experts what we had today. Thank you, Dr. Neminathan, and thank you, Dr. Prasanna, for taking your time out, even in your busy schedules. It's not easy
Yeah.
for all of us to, because it's all our family times. We are recording at late 10:45 in the night. I'm pretty sure everybody in the family will be cursing us. So, even with that difficulty, you've spared your time. I think I should be thanking you a lot, sir.
Thank
Any
you,
closing
Manju.
remarks, sir?
Yeah. Definitely. I need to add a point because next November 18 to 24th, we are celebrating WHO Antibiotic Awareness Week. So I would insist all the doctors, viewers, to use a 5-point rule in your day-to-day practice. Whenever you see a child with fever, first point number one is how did the fever start? Abrupt onset, ultra short incubation period, viral, whereas prolonged incubation period, bacterial. So no antibiotic. Number two, more than one member in the family having fever at the same time, it's probably viral, ultra short incubation period. So this also brings the pendulum towards viral. And third is very important, multiple sites involved. Eye is red, nose is watery, throat is congested, probably viral. Multiple systems that are involved, respiratory, GA, skin, probably viral. Whereas bacteria localizes to only one system, bacterial dysentery, bacterial osteomyelitis, bacterial UTI. So only one system, bacteria, multiple system. And the last fifth point is very important. Now, how does the child look between the two fevers? That's called interfebrile period. If the child is up and about playing between two fevers, probably swings the pendulum towards virus. And in bacterial, though the fever comes down in a enteric fever or pneumonia, child is still dull because of the tissue hypoxemia and other things. So if the child remains dull, it's probably bacterial interfebrile period. The child is up and about viral. So if you apply this 5-point rule in your practice for every febrile child, you can reasonably come to a diagnosis. It's a short pyrexia illness, probably viral. You have to educate them about, counsel them about danger signs. Do not prescribe antibiotic. You can even write no antibiotics, write your name, signature, medical council number, everything that will protect you in the court of the law. So just if you are very scientific, you can reduce the prescription. My prescription, when I finished my postgraduate and started my career, my prescription was very high with antibiotics because I did self-auditing. After self-auditing, now my antibiotic prescription is less than 9%. 91% of the time, I don't prescribe antibiotics. Less than 9%. I do audit for myself. So everybody has to do a self audit. Definitely, we should bring down our antibiotic prescription. I'm sure that we'll all celebrate happily our antibiotic awareness week in the next week. Thank you.
A striking message for the youngsters who will be listening to this, sir. Thank you, sir.
Thank you so much, sir.
Yeah. Once again, closing remark. Once again, all fevers are not infectious, all infections are not bacterial, and antibiotics are not antipyretics.
Yes,
True, sir.
very good message, sir. Thank
Yeah.
you all, and thanks to Dr. Neminathan for sending a message to me and starting this new venture. I'm really happy how it has turned out, and hopefully, a lot of pediatricians and doctors, and including patients, will get benefited with this discussion. Good night. Good night, to everybody.
Thank you. Thank you. My appreciation to Manju. You're doing a good job. And Prasanna, my friend, is doing a very good job in Chennai. I wishes and appreciation to both of you.
Thank you, sir.
Thank you, sir. Blessings from you is
Thank you.
so important for us, sir.
Thank you. Thank you.